and thanks to PPR Medical. If we could have my presentation up, please. Okay, so next slide. I've got the topic of giving some background information about nitrous oxide, essentially outlining the problem as it looks today in the NHS. I'll start by covering some basics about nitrous oxide as a greenhouse gas, its use as a medical gas, how this translates into a carbon footprint, and attempt to quantify that somewhat. I'll mention some ways that we've been trying to reduce our nitrous oxide use, and then I'll briefly move on to what and how feasible any alternatives may be, concentrating mainly on its use within a maternity setting. I'll use obstetrics to illustrate the occupational exposure considerations of nitrous oxide, and finally I'll touch upon some personal experiences when it comes to sensitivities around trying to champion responsible nitrous oxide use and options for reducing it. Next slide, please. Nitrogen oxide is a greenhouse gas, meaning that within the Earth's atmosphere it absorbs and then emits radiant energy within the thermal infrared range, thus contributing to the greenhouse effect. Once there, its atmospheric lifespan is about 109 years. So it's important to think then that every molecule of nitrous oxide that is given will outlive the person giving it and also the person using it. It's the fourth most abundant greenhouse gas in the Earth's atmosphere by molar fraction, and the current tropospheric concentration is about 325 parts per million, and that's increased by about 20% since 1750. And this increase since the Industrial Revolution is entirely anthropogenic and continues in a linear fashion. Due to both its molecular structure, its efficiency as a greenhouse gas, its long-lived atmospheric lifespan and abundance, the global warming potential of nitrous oxide is about 273 times that of the reference gas carbon dioxide over 100 years. And finally, if that wasn't enough, nitrous oxide has a potent ozone depleting effect too, and all the inherent health problems that come with that. Next slide, please. Inhaled nitrous oxide provides excellent analgesic and mild sedative effects. Many of its properties actually render it an ideal agent for these purposes. It's cheap, non-combustible, easily stored and administered at room temperature, has a rapid onset and offset. It's effective, unmetabolized and unreactive with other medications with minimal side effects in the short term therapeutic use for the patient, which may also include a baby, obviously. Its administration doesn't require too much additional staff training or patient monitoring. It's maybe no wonder then that it's persisted for about 250 years as either part of general anesthesia, but also to provide procedural analgesia and sedation in endoscopy units, dental suites and emergency departments, and of course in maternity units for labour analgesia. Next slide, please. Most people will see in this pie chart the total NHS carbon footprint in England was estimated in 2020 to be about 6.1 million tonnes of CO2 equivalents, and that's scope 1 and part of scope 2. 5% of this is associated just with anaesthetic gases, and 80% of that is nitrous oxide related. Annually, it's estimated that that translates into about 250,000 tonnes of CO2 due to nitrous oxide, and by far the biggest users are maternity services, being either mixed with oxygen as Entonox or for its theoretical uterine relaxation sparing effect when given as part of an anaesthetic in obstetrics. As a direct emission, nitrous oxide falls within scope 1, as I've already mentioned, where the requirement will be absolute zero rather than offsetting net zero. Next slide, please. Local data within NHS Lothian maternity units, which appear to be reproducible elsewhere, reveal that about 70 to 80% of all deliveries use nitrous oxide at some point during the birth process. We have estimated our carbon footprint per delivery to be about 256 kilograms of CO2 equivalents. However, on one site we discovered that about 80% of our nitrous oxide never actually sees the patient, presumably due to loss in the system, but also due to poor stock rotation and returning of full or partially full cylinders. And one site may have even had a carbon footprint per delivery of almost double that. When faced with our massive nitrous oxide carbon footprint, we started the nitrous oxide mitigation project, which went back to basics. We studied clinician behaviours and beliefs and tried to establish if there actually was a role for nitrous oxide at all in modern anaesthetic practice. We studied hospital schematics to understand which clinical areas were supplied with nitrous oxide, and after engaging with clinicians, turned off and decommissioned almost all manifolds so far, saving not only on waste, but also on capital outlay for maintenance. We aim to decommission all nitrous oxide manifolds and offer portable cylinders on anaesthetic machines where clinicians still feel it is a requirement, such as in obstetrics and paediatric theatres. However, in the future, we may be able to change practice and avoid its use in these areas too. One additional step we've taken is when someone's using nitrous oxide and comes to a labour ward theatre, rather than using the anaesthetic machine to provide ongoing Entonox, which gives a continuous flow of gas, we've now got mobile cylinders with a demand valve that will only supply gas on inhalation. Next slide, please. Alternatives in labour, when required, can be less effective, such as the non-pharmacological options at the bottom of this pyramid, or more invasive than nitrous oxide, such as epidural analgesia, or combined spinal epidural analgesia at the top there. They can be associated with undesirable side effects for the mother and the baby, such as the injected opioids intramuscularly or intravenously via patient-controlled analgesias. They may require additional monitoring as a result. Additional staff time may be required too for these alternatives, which may be delayed, such as when an epidural is requested, and attending staff may require further training in their monitoring and management. Nitrous oxide can be very effective as a labor analgesia when time to contractions wears off in between, and for all these reasons it's unlikely that nitrous oxide will be going anywhere anytime soon from maternity delivery units. Many of these same issues apply to potential alternatives out with the maternity unit too, such as with more traditional bolus drugs like opioids, benzodiazepines, ketamine, inhaled methoxyfluorine, or infusions of propofol. Next slide, please. Nitrous oxide falls under control of substances harmful to health regulations, and with the Health and Safety Executive giving prescribed limits on occupational exposure, and this limits workers to 100 parts per million over an 8-hour time-weighted average. Long-term nitrous oxide exposure is associated with several possible ill effects, including direct neurotoxicity causing neuropathy, myelopathy, and subacute combined degeneration of the spinal cord. Similar effects are also thought to result from nitrous oxide causing vitamin B12 deficiency, which can result in megaloblastic anemia. Nitrous oxide can also affect DNA synthesis, and for that reason, it's been recommended that workers in the first and second trimester of pregnancy avoid exposure. And this may explain the possible subfertility and infertility seen amongst such workers. Although well known, it appears that only recently in the UK there's this increasing awareness of these issues and drive for change. Occupational exposure may be mitigated somewhat by active ventilation of delivery rooms or by anaesthetic gas scavenging systems, supplying those areas to capture and remove exhaled gas. But these mechanisms do nothing to mitigate the harmful effects of nitrous oxide on the Earth's climate, which I've already outlined. Next slide, please. I think we do have to be a little bit sensitive, though, when discussing sustainability considerations for nitrous oxide in the maternity setting. We have to consider the possibility that highly vulnerable people who are suffering may not wish to know or be guilted about climate impacts of their healthcare choices. There's been some concern that publicity around the significant climate effects of nitrous oxide may risk its removal completely, and we must reassure them that this is not the case. People have a right to choose what analgesia they wish to use in labour. Should people in labour be burdened at all with the environmental considerations of nitrous oxide? On the flip side, often people are entirely unaware of these considerations, and some actually preferred to know when it was explained to them, and it said they may have even chosen to use an alternative method of analgesia as a result of this knowledge as part of patient choice and informed consent. Next slide, please. So nitrous oxide, the bottom line, it's a significant carbon contributor and ozone depleter. As a scope 1 emission, we need to find a way of achieving absolute zero. It remains widely used, especially in maternity services, where it provides an effective and safe labour analgesic. However, there are concerns for staff who are subjected to long-term occupational exposure. Medical use of nitrous oxide is a problem that can no longer be ignored, and we all have a role to play. It requires an effective, cost and time-efficient, reliable solution against emission and exposure to be developed, which can allow continued use where clinically appropriate. Thank you.